Yeah, thank you very much. So now it's time for the real stuff. So after the heart failure nerd, after the musician, it's time for electricity. So I would like to just pick a few points in order not to have too much overlap also with the previous talks. And I will just really try to give you the way how we see electrical storm. So I would like to talk about the ventricular arrhythmia and then underlying heart disease characterization, the antiarrhythmic pharmacology care treatment very short, the autonomic modulation, optimization of ICD programming, and catheter ablation at the end. I will try to support my opinion and data on the recently published DSC guideline, which fortunately was written by, as first author, as chair, Dr. Zeppenfeld, who is one of the most expert catheter ablationists, I think, in the world, but surely Europe. And the other document that I will sometimes refer to is the 2019 expert consensus statement on the ablation of arrhythmias, ventricular arrhythmias. So let's start with the first point about the characterization of the ventricular arrhythmia and underlying heart disease. And indeed, so I also find that very important that when we think about the arrhythmogenesis mechanism in electrical storm, and electrical storm as defined indeed the more VT or VF episodes, sustained episodes, it's very important to think that it's always a combination of several factors. So the substrate, that's what the underlying heart disease, what Fred also talked about, can be either a channelopathy, when we don't see on Kaurus MRI too many things, or it can be a myocardial scar. There is a trigger, which sometimes are overrated triggers, as ischemia, heart failure, inflammation, electrical derangements, and drugs, except heart failure, of course. And then we have the autonomic dysregulation. I think Tim talked very nicely about this already. Now, the arrhythmia mechanism, I find it very important to understand that we have two different kinds of mechanism. One of them is re-entry, which is usually in the setting of the scar, as Pedro has very nicely alluded to this morning. Or it's based on early or late after depolarizations, when we talk more about a triggered form of arrhythmia, either focally or diffuse, depending on the underlying heart disease. Now, this is what leads to electrical storm, actually. So starting with the classification of the ventricular arrhythmias, so the 2022 guideline actually made it very simple. So it's talking about polymorphic and monomorphic ventricular arrhythmias, and the whole strategy is based on this classification, simply based on the ECG. Is it polymorphic or monomorphic? I'm sure that Frederick is not very happy with that, and I think a little bit that he's right. It's true that when physicians, when we see as ECG with a VT which is fast, I think some of us, or many of us, we start actually we tend to stop thinking, but I think it's on a good purpose. If I start to think at that point too much, and I think about Miguel's alcohol or about the bipolar ablation, instead of, so at that point in time in these patients, I think it's extremely important to make it simple in the beginning and stabilize the patient first. However, and that's why this classification of monomorphic versus polymorphic ventricular arrhythmias may be useful at the beginning. However, I entirely agree with the heart failure nerd that the diagnosis of structural heart disease and underlying channelopathy is a key after the first 20 minutes in the treatment of these patients. Why is that? Because if the patients, we know what the patient has underlying, that will define what's the mechanism of the arrhythmia. Is it re-entry or is that focal? That will allow disease-targeted therapy. And that will also determine the short and long-term treatment success and the complexity and efficacy and safety of ablation. So just to come back a little bit about the etiology. So as we said, so there are patients with underlying structural heart disease with scar, ischemic cardiomyopathy, non-ischemic, and I think Frederick has very nicely alluded to all of this. And there are the channelopathy patients with a structural normal hearts. However, today, if we see a real electrical storm patient coming to the emergency department or ICU, what we see that the majority of patients, it has always been like this, has ischemic cardiomyopathy. More actually here it says 45%. I would say that's even more than that. Or ARVC is rarely. These are all scar-related arrhythmias, or HOCM or HCM. DCM, dilated cardiomyopathy, is also scar-related reentry, and only a minority of patients will have idiopathic ventricular fibrillation. So moving on to the treatment, so we have, depending on if it's monomorphic or polymorphic, and depending on the underlying etiology, we have the different treatment algorithms. I will only talk about on the electrophysiological part of this treatment. So just very shortly about antiarrhythmic pharmacological treatment. So I think Tim already nicely talked about the beta blocker amiodarone. If it's a monomorphic, usually scar-related arrhythmia. There are some exceptions. For example, in long QT, I find it also important that there are other medications. If it's acquired, then we should think about pacing, magnesium and kalium supplementation, and antiarrhythmics according to the underlying disease. I will come back to that. Quinidine is coming back indeed. I don't understand that. So it's always that in these guidelines we are having chapters, and I have reviewed actually the SCD guideline, and I have been saying that I do not understand why quinidine received without any new data an upgrade to 2A indication. I also have problems with that. But yeah, so quinidine is an option in patients with idiopathic VF actually. In polymorphic VF triggered by unifocal PVC, I don't even agree with this because these patients have sometimes subacute myocardial infarction. I will show an example of that. And then, so what I would like to just, we talked about mexiletine, so somebody has mentioned it. So it says, because when I called to the pharmacy last week, they told me my mexiletine doesn't exist in Belgium. So I would like to say that mexiletine for the arrhythmologist should be in our armamentarium because it's absolute class 1 indication in long QT3 syndrome. But we even use it in combination therapy actually for therapy refractory electrical storms. For the rest, procainamide, I have to say that in my previous workplace, we used to have a vial in the fridge because it's not available in Belgium, specifically ordered for this very special monomorphic VT patients from France. But the two basics of the pharmacological treatment are indeed amiodarone, beta blockers, and sometimes lidocaine. Autonomic modulation, I think, very nicely talked about this. So in our current guidelines, it's in monomorphic arrhythmias is 2B indication. In long QT and CPVT, where the sympathectomy is extremely important, it's 2A indications. I completely agree with Tim that I think we should use this therapy much more. There is a very nice review from an Italian colleague who is doing this regularly. It's a fact that it's 2B indication because the largest study included, I think, like 30 patients. But it's a therapy which is transiently can be life-saving, and it saves us to have to come on Saturday, for example, to do an urgent ablation. So I completely agree that we should use it more. Regarding the ICD programming, so this is a very important point which we neglect sometimes. So why do I find it important? Because the ICD has exceptional diagnostic capacities, and this is how we start when we are seeing these electrical storm patients before the ablation, because it will tell us how the ventricular arrhythmia initiates, characterizes the arrhythmia, is it monomorphic, polymorphic, tells us the cycle length. We can also use it to pace at a higher rate, as I will show in an example, to prevent bradycardia, pulse-dependent VT-VF. And we don't need to put a temporary wire as in patients who have ICD to terminate with override pacing, do an ATP, but we can program it in the device. Now, the disadvantages are that the shock also provokes pain, emotional distress. This, we should really not underestimate this. If you see these patients in the clinic, they have sometimes very special stories. And this can further exacerbate the electrical storm. And finally, the one group of patients is very difficult to deal with when the VT is really very slow, 100, 120 beats, like, for example, that patient we just did yesterday. Now, the aim of the programming is to avoid ineffective shocks, avoid inappropriate shocks, and avoid repetitive shocks. And that's the reason why when the patient comes in, either on the emergency, either in our very special ambulance or to the ICU, there should be everywhere a magnet ready just to deactivate the shock function of the ICD, also for the long-term mental health of the patients. And then only elevate this when the patient is lost his consciousness, or when the patient is sedated, or what we usually do when I hear that you call me because there is a patient on the ICU, what I like to do is that I simply program in the VT zone the VF therapy is off, and we only program a very, very aggressive several episodes of ATPs, getting from more and more aggressive, in order to avoid shocks. Be careful because the ICD can also cause proarrhythmia. It can accelerate the VT and degenerate the VT to VF. And also be careful about the new CRT devices, about the proarrhythmic effect, which we see sometimes of LV pacing. Now, I find it very important to mention that because this has happened once in the past, that before we discharge the patient home, the ICD should be reprogrammed. So I do never let a patient go home without, in the VT zone, without shock therapy. So just to mention that. And also I agree that here comes the heart failure nerd. Again, so once we treat the electrical storm actively, then it's very important. The next step is to think about the long-term further steps. And finally, our favorite, so the catheter ablation. I still have a few minutes. So so catheter ablation is a very important part of the treatment of electrical storm, and we are not the only ones saying that. So in this large single center experience, catheter ablation was applied in the ICU patients treated with electrical storm in 37% of the patients. I also find that the rest of the therapies were less frequently applied, which is maybe not completely representative. But deep sedation, support, autonomic modulation, and also use. Now, in this, as I said, so most of our patients with electrical storm are ischemic cardiomyopathy monomorph VTs. And what's very important to know that these patients have a very, very, very high one-year mortality. I think it's in this study was 34% because it was about ICU patients. And as Eve already said this, so the predictors of mortality is the age, left ventricular ejection fraction, right ventricular dysfunction in this study, and anemia. Now, how these patients look like? So compared to our usual ablation populations, 90% of these patients are males, usually 60, the mean age of these patients who are taken to the lab to be ablated for an electrical storm, around 64 years of age. So they are older, they are more likely to be men. They have a lower ejection fraction and much more comorbidities. Now, how does this procedure look like? It's not the funniest procedure. So I'm bringing this data because sometimes I get this critic that the evening pizza is ordered from my dear EP colleagues after my procedures because I'm taking too much time. So if you see this study, the ES ablation mean time, procedure time was 296 minutes. So that's 5 hours. Although in this study, as you see, the usual VT ablation was also 4.5 hours. So further, in patients with ES as compared to our usual VT patients, the procedures are, as I said, longer. They have usually more VTs. And unfortunately, our endpoint, which should be in every single ablation of VT ablation, non-inducibility, is only 64% of the patient achieved with one procedure. In hospital mortality is 6.2%. So I think that's very important when we talk to the family, if the patients are sedated, that all this data should be discussed if the patient can still talk, then with the patient or otherwise with the family. Now, regarding as I said, with the 1 year VT recurrence, because this is also, I just got last week this question. So in this large series was 32%. So that's what I usually say, that so with an ablation, we can treat the electrical storm in more than 90% of the patients, but at 1 year, we will have in at least 1 out of 3 patients recurrent VT. These are single episodes usually, but this is important to know. And if is the number, how many, so what's recidive electrical storm and recidive VTs we have is dependent on an endpoint. If we manage during the ablation to get the patient at the end of the study non-inducible. So this is a very important target and important information. Now, if we look at the mortality, and here comes again, I entirely agree with the notion how important the underlying heart disease is. Because if we see at the 1 year mortality, the previous study was 32%, here is 20%. So these patients are really sick, and the most frequent reason for death is actually heart failure, 55% of the patients. And so other predictors of recurrence is the septal scar. That's why we had Miguel here, for example, in one of these patients also yesterday. Patients who have septal scar, because usually the most frequent etiology in these patients is non-ischemic dilated cardiomyopathy, as our patients with laminase mutation, it was yesterday. If you have a septal scar, both the VT recurrence, rehospitalization, and cardiovascular mortality is higher. Is it because these patients have a diffuse support, or is it because we cannot reach it? That's a question to discuss. Now, the indications, it's very easy. Everybody with electrical storm with monomorph ventricular arrhythmias has a class 1 indication for catheter ablation. And if the arrhythmia is polymorphic, then it depends on the underlying morphology and depends on the characteristic on the ventricular arrhythmia. So if the idiopathic VF, if the initiating PVC is usually the same morphology, or in ischemic subacute myocardial infarction, it's usually 2A indication. These patients we can still help with the ablation. And so how does this procedure looks like? For us, it's a key to have the 12-lead ECG morphology at anytime we go in the hospital, we say this, how important this is also for the nurses, colleagues who are here, and intensivists, how important it can make the difference between a successful and failed procedure if you have a 12-lead ECG of the arrhythmia. Now, the only contraindication for ablation, this is the only second question I always ask, to make sure that the patient doesn't have left ventricular thrombus. So it seems in this large series from Bordeaux with imaging before the procedure that about 11% of the patients who come for a VT ablation in general have intracardiac thrombus, out of which less than about 7-8% is the left ventricle. So these patients, we usually are contraindicated for endocardial ablation, or there must be a very special reason why we put them on the table. And so I just would like to come back to this point about the ischemic evaluation. Yes, it's very important to exclude ischemia in this patient. But for example, in this study, so if a patient comes with a known ischemic heart disease, known scar, and comes with a monomorphic VT, not all these patients need a coronarography, because acute ischemia is not likely to be the cause. Acute ischemia is causing polymorphic arrhythmia. So for example, in this patient population of 97 consecutive patients with monomorphic VT, if they had an ischemic evaluation or not, the outcome was exactly the SADA, because that's not the problem. And I liked very much from Dr. Kumar this editorial saying that old habits die hard. So still every patient with monomorphic post-infarct VT, many times the first thing we do revascularization. I mean, we do a coronography. We have all CTO. I will show you an example of this. And then revascularization, that's not going to solve the problem. Sometimes even worsens them. Now about the temporary mechanical circulatory support, I would just like to say that there is a recent team also showed this. There is a recent meta-analysis, and it seems that if we do in very sick patients, high-risk patients based on the PNA score, if we do in high-risk patients prophylactically before the ablation, the temporary mechanical support, the outcomes, the mortality is lower than if you do it rescue during the procedure. So this about the pre-ablation planning. So I think this PANA score is very important score that may be useful, especially also in the ICU when we are considering ablation. Patients who have more than 15, 17 have a high risk of having hemodynamic decompensation during the VT ablation. So for the rest, I think it's important to categorize the apnea, try to see if it's monomorph or polymorph, underlying heart disease to exclude or to characterize. It's important to optimize the patient, that we can do this procedure we try to do it when the patient is stable as for example, they surely do not have hypokalemia. So regarding the safety consideration, the left ventricular thrombus is important, the anesthesia plan, and the LV access plan, that's usually obvious. I think I don't have too much time, so actually I ran out of time. May I, from the chairs, show one case or two?
Sure. Yeah, because we need to have some time for discussion. One case.
One case. Okay. So who wants to see the long QT, which is not long QT, and who wants to see the subacute MI? So I don't know which case. I will show the long QT case because it's from Brussels. So this was a lady, 71 years old lady, who was treated with recurrent epilepsies and presented with syncope. So completely normal coronarium echo and ECG, non-inducible at EP study. We induced a significant AV prolongation. So we thought the patient had a paroxysmal AV block. So she received a pacemaker. Now 1 week later, this lady comes back with polymorphity, and we have a QTC of 480. So we diagnosed it with long QT, the patient, and given that in spite of pacemaker had recurrent recurrent syncope and VT, she received an upgrade to ICD. However, a few weeks later, the lady comes back, and we have this unique opportunity to document VF on a 12-lead ECG, which is a very bad sign. But if you see here, and the ICD shock, but if you see here, the patient had in the last a month or weeks, actually 70 device total 77 therapies, 15 shocks. So we make an ECG in these patients, and this is what we see. We are seeing atrial pacing here. And what we see that the patient has actually ventricular extrasystoles with relatively small QRS morphology with this right bundle and left anterior fascicle morphology, recurring always and then going to VF. So this is a case of a monomorphic PVC inducing a VF, which has been very nicely this case has been done in 2011 when my procedures were lasting a little bit shorter. But it already was published from Dr. Hesseger's groups also the data on the Purkinje system, which has been very nicely characterized in the last years. And you see how this in the left anterior fascicle region, how this arrhythmia is initiating with Purkinje fibers, with Purkinje activity. And so we were simply with focal ablation, we were able to treat these patients, and she didn't have any recurrence anymore. But the diagnosis was not long QT, but it was idiopathic VF initiating the Purkinje system. And I think I will just stop here. No, one. Sorry about that. I cannot stop. But I would just like to say, of course, that. So I leave my conclusions, but I think why we chose for this title, what's indeed I find extremely important is that also in the treatment on electrical storm, it's very well represented that multidisciplinary approach is very, very, very important. So that's the reason why we are actually getting together, and it's my dream, and I hope you join me. All the other departments are joining us in that we create this VASCAM unit, which means that we get all together, put our best knowledge, best equipment, best organization together to help the patients on this journey from the beginning to the end of their life, preventing and treating sudden death. Thank you. I stop here.